Showtime.
Good afternoon and welcome to Africa Media Corporation, Africa Online Media Corporation. It is the 27th day of the month of October, and as we always do at the end of each month, we handle a health topic. This month, concluding the month of October, we decided to handle the topic malaria in Africa. Malaria, that strange person or strange thing in the room that haunts Africa, that scourges Africa and Africans, especially most of the countries south of the Sahara and north of the Limpopo River. So it is in tropical and subtropical Africa that malaria has become a great menace to people. It is among the top 5 killers on the continent. Malaria, strange as it may be, mosquitoes bring it to us. We have sleepless nights, we go under nets, we spray our rooms and so on, but then the scourge of malaria remains. So in order to get this topic started for this Sunday's discussion, let me do a reflection. It may not be the one you expected, but all the same, it is our reflection. And so here we go. Our reflection on homosexuality last week ended with our usual invitation to you, to all of us, to Africans, to join us in this platform or on this platform so that together we shine the light on those things that make life nearly unlivable on the African continent. Pursuant, therefore, to that invitation, we focus today on malaria, that disease that scourges the continent, that disease that makes life miserable in the tropical and subtropical regions of Africa in particular, and the entire world in general, that is subtropical regions of the world. In keeping, therefore, with Africa Online Media Corporation's mission and vision, on this last Sunday of October, as we already said, we tackled that topic, malaria. Is it a scourge, as we just said, or is it just another of those illnesses that come about and invade you? Whatever it is, malaria is not a friend, but it is a great enemy. While a Google search tells us that malaria is, quote, an intermittent and remittent fever caused by a protozoan, a parasite that invades the red blood cells of the human body, that is, other sources say that malaria, quote, is caused by the Plasmodium parasite, which can be spread on humans through the bites of infected, quote, Anopheles mosquitoes. They're the female ones, I believe. According to the World Health Organization, WHO, therefore, there are 219 million malaria cases worldwide as of 2017. Of that number, 435,000 were recorded as deaths, and an estimated $3.1 billion is set to be available as of 2017 for the fight against the disease malaria. Malaria is found in more than 100 countries. According to the World Health Organization, the 6 highest burdened countries in Africa are Nigeria, the Democratic Republic of Congo, the United Republic of Tanzania, Uganda, Mozambique, and Cote d'Ivoire. These 6 countries are set to account for an estimated 103 million or 74% of malaria cases. There are said to be 5 types of malaria in the human being, but that the complexity of the malaria parasite makes its development difficult to handle, and of course it is a problem that the continent and the World Health Organization have been working to see how to go around. But hope has recently been reincarnated as the WHO-led implementation program is piloting some vaccinations in East Africa, especially in Kenya and I think Somalia. The fact is, this vaccine is just recently developed and is being tried in that part of the continent. When we discussed the topic 2 years ago, we quoted experts as describing malaria as a life-threatening disease caused by parasites that are transmitted to people through the bites of infected female Anopheles mosquitoes, as we already said. But that description was true then, as it is today, because malaria remains the person or the thing that is, and though preventable and curable, malaria requires a lot more of concerted efforts by both you and I, by the international community, by countries, by governments, and by everybody else, so that lifestyles can be improved, so that, of course, this malady can be arrested. Lifestyles in affected areas, however, remain a stumbling block as environmental factors greatly hold sway in many countries. Mosquitoes thrive on dirt and dirty environments, and until and unless humanity makes it a collective initiative, malaria will remain a scarecrow, easy to identify but hard to beat. Educating the public on the need for clean environments thus remains a task that should not be neglected. Education on the environmental cleanliness or on environmental cleanliness must be accepted as a priority, and governments in affected areas should allocate necessary and sufficient resources for the fight. It will only pay off when such environmental cleanliness and research for anti-malaria vaccines continues. That is already paying off, and hope is not yet lost and should never be lost anyway. So let us conclude on the words of T.K. Nalaika, who says, malaria prevention and eradication should be inspired by General George Patton's advice, quote, a good plan executed violently today is better than a perfect plan in a week. In this war of attrition, continues Nalaika, millions of people will be lost while waiting on researchers to finally emerge triumphant from their labs with the perfect malaria cure. Yet, meanwhile, there are plenty of time-proven practical actions that individuals, families, and communities can do today, so that with that, they can already bring to arrest, or rather, they can come to defeat the malaria transmission if applied with vigor and discipline, as well as with consistency. That said, Reverend Palm, I think at this point, let us open the door to our guests. I already can see Dr. Khumbah in Dakar, Senegal. I think she's on the line. But first to you, Reverend Palm, what is your take on malaria?
Thank you so much, Nia. So, as you know, I'm driving.
Yes, you are driving and we're hearing some background noises. So let me just let you go to a stable place. I will get over to Dakar so that Dr. Khumbah, who comes from one of those tropical areas where malaria is present, to have her word and have her say. Dr. Khumbah, good afternoon or good evening according to your time zone.
Good evening to me and good afternoon to you.
Thank you. Yes.
Yes,
go ahead.
It's good to be back on this program and talking about something as important as malaria. I could hear you talking.
Dr. Khumbah, we can hear you.
I heard you talking in your editorial about, giving some facts about malaria. If I start off with malaria, I want to say that malaria is a very serious problem.
You're farther away from your microphone than usual.
Well, I'm not.
Oh, okay. Okay, go ahead, go ahead. I know Reverend Pam is not getting you clearly, but she's driving, so that may be one reason.
Yes, I was saying that malaria is a very important problem. It's a very pertinent health issue because through the decades, through the, centuries, malaria has been a serious problem in Africa, and unfortunately, it continues to deepen rather than improve. It continues to worsen rather than improve, despite all the landmark efforts, all the research and research outcomes. Malaria continues to be life-threatening and even worsens. But that said, I want to say that we need to understand a couple of things about malaria. The first is that malaria is essentially a disease of sub-Saharan Africa. Why do I say that? I say that because statistics shows that in the world over, there are about 300 to 500 million people infested with malaria. the bulk of that is in sub-Saharan Africa. So you can imagine, sub-Saharan Africa, we're talking about a number of countries, and those countries contribute, the population in those countries we're talking about is about 2.4 million, which is over 40% of the world's population. So malaria is a very serious global problem, even though the brunt of it is borne by the Africa south of the Sahara, the region of Africa, in sub-Saharan Africa. It's very important because globally, when we're looking at these figures, we are also looking at why are these figures an issue? They are an issue because of the increase in travel. We are no longer living in a secluded place. We are all traveling all over the place. And if malaria is endemic in sub-Saharan Africa, and then people are traveling from sub-Saharan Africa to other places, the question we want to ask is, along the way we'll talk about it, are they taking this malaria to those other places? Why is malaria endemic in sub-Saharan Africa? It is because of its own biology. What is malaria? The biology of malaria is very important in identifying where it is located. Now, in sub-Saharan Africa, there is, first of all, let me say that malaria is transmitted by the female Anopheles mosquito. That's what, I mean, that's basic knowledge that almost everybody knows. But this mosquito has a certain species of it, a certain subtype of it called Gambier, which is more prevalent in the sub-Saharan African region, and it is the one that bears the most prevalent form of malaria. When I talk about form of malaria, malaria is caused by a parasite. We call it Plasmodium. But that Plasmodium has different subtypes again. There are hundreds of subtypes of Plasmodium. But the ones we are very interested in are falciparum, that's Plasmodium falciparum, Plasmodium vivax, Plasmodium ovale, Plasmodium malariae, and now we're talking about Plasmodium knowlesi. But the first four, that is falciparum, vivax, ovale, and malaria, are very, very important in this disease process of malaria. They are very important. And they are born and transmitted, not all of them, sorry, the falciparum in particular is transmitted by Anopheles gambier, which is very common in sub-Saharan Africa. Now, and it is the most virulent form, that is, it is the most deadly form of malaria, the falciparum. And that's one that is found in sub-Saharan Africa. That's why the burden of malaria is in sub-Saharan Africa. So the reason, the presence of the mosquito and the presence of this type of species of the malaria in question, of the parasite in question, those two factors make it that the malaria that we worry about more is most prevalent in sub-Saharan Africa. And you know, we're talking about sub-Saharan Africa. When we are now looking at other issues, or when we're looking at the global picture, sub-Saharan Africa is tagged as the area with most of the poor countries. You know, these developed countries are found in sub-Saharan Africa for the most part. So we are now associating it with poverty. We're now saying that the people are poorer, yet they have to bear the burden of this disease. And this disease is very important because it's around. It's called endemic. When we say endemic, we mean that it is around. It's common. It's not rare, it's common. And you know, when you start saying it's around, it's almost as if it's a companion to the life of people in sub-Saharan Africa, malaria, which is not a good thing because it remains a disease. It's, when we say it's a companion, it doesn't give it it doesn't give the impression that it's a good companion. It's a disease. It's a disease, and for it to be a companion, it's not a very good thing for sub-Saharan Africa per se. That's why a lot goes into it. You know, a lot of research, countries, everybody is on there. And way back in, even in through the decades, there's a lot done to fight malaria. In 2000, there was a big rural malaria project launched in Abuja, Nigeria, I think, and which has gone from step to step. I heard you talk about the vaccine. The vaccine was launched earlier this year in Malawi. And it is a very big step because when we talk about the burden of a disease as heavy as malaria, in practice, in the medical profession, one of the main things to do is prevention. You know, I remember growing up and hearing the statement, prevention is better than cure. And that statement was coined in 1978. Prevention is better than cure. Because when you prevent it, you don't have to worry about the cure. And it's always cheaper. Reason being that if you are working only on the cure, for example, not only is it economically stressful on economies, it's also very stressful because the people will not even come for the cure. If you are waiting for people to come to the hospital to be treated, for example, do they have money to come? There is a lot that goes into cure. But if there are preventive measures in place, which can already help us to avoid getting to the disease and talking about cure, we do better. It has happened with many other diseases. It is hopefully going to happen with malaria. But like I was saying as I started, malaria is worsening. It's not improving, despite all the landmark efforts put into it globally, and especially with special focus on endemic area, which is sub-Saharan Africa. It is still today, 30 years after, people are still dying of malaria more than they did 30 years ago. It's embarrassing, but it's the truth. And when we're talking about it being endemic, what is our worry? Our worry is that it has a very high mortality rate. It's a cause of death. About this, I think it's the second most mortal situation that people have in sub-Saharan Africa. And globally, about say 1.5 to 2.7 million is a big range because of the kind of statistics we can get. But research shows that between 1.5 and 2.7 million people die of malaria annually. Many of those are children, and 90% of those are in sub-Saharan Africa. You know what we're talking about. It means that the burden is heavy. We're talking about mortality. We are not looking at morbidity yet. Mortality means that people are dying. Morbidity means that people are incapacitated by the disease. Morbidity is very high because if you live around sub-Saharan Africa as I do, and if you observe around you, how many people in 1 month don't go to work because they have to. So that's what we're talking about. That's what is called morbidity. Morbidity is very high. It's very high, and it is a problem. So you see that not only is this burden a life-threatening thing, it is an economic stress. It's a sort of serious economic stress because of the cost of handling it and the morbidity of it and the mortality. You know, all those factors put together make it economically very stressful as an issue. So malaria is a very important issue. I'm emphasizing on sub-Saharan Africa because in the recent past, other parts of Africa, especially the northern part, the Maghreb, there have been talks of eradication of malaria. But like we are saying, even the global, the level of travel makes it that nobody can really say that they don't have malaria per se in their country. But in the Maghreb area, especially, you know, we are talking about Algeria, Egypt,
Morocco, Tunisia.
Yes. They have battled because they don't have the Anopheles gabiae, who is the killer mosquito. They don't have that. They have other species, and the species of malaria they also have used to be Vivax. Vivax is a little more is easier to handle. Falciparum is the deadly and more difficult one. So there are some favorable factors, if I may call them that, which were able to bring some level of eradication to them. But when we talk about eradication, as a medical practitioner, I always say that when we say eradication, we say it with care because it's not zero. We will not say that in those countries it is zero. We will not say that it's not zero, but at least it has been contained. Unlike the sub-Saharan African situation where it is still such an endemic situation. I mean, almost every patient who walks into a consultation may end up having malaria if we check it. So it's a serious problem. It's a very serious problem. And
now, doctor, not to cut your line of thought, I just wanted us to go to the very beginning. What are some symptoms of malaria? How does one know that one has malaria? Is every fever malaria?
I will get to that, but I was trying to
lay the groundwork.
I need to be able to get your listeners, get who are listening to us, to understand the weight of the problem. That's why I started because it's a very serious problem.
Okay, go ahead.
Some of the people hearing may be people involved in policy. Are we taking it seriously that we need to work on malaria? Are we making it a money-making process? You know, we do health programs instead of looking at how the population can do better. We are looking at how we can make money. So it's a heavy problem, and this we even though say it's endemic, as we are saying, in this huge population of 1.7 to 2.5 million people. We are saying that it is even worse in children below 5. The disease weight is on children below 5 and on pregnant women for obvious reasons, immunity problems. You know, people, especially first pregnancies, women immunity will be low, and then children below 5, their immunity may not be too good yet. Especially, we say below 5, but the highest rate is below 2. So imagine in the first 2 years of life, children dying of malaria. It's a serious problem. A child will not see second birthday because of malaria. How many children do not see their 5th birthday because of malaria? It's a very serious problem. But back to your question then, we say that if people have malaria, how do they know they have malaria? I'm going to talk about the clinical presentation and possibly how it's handled. But I want to say here before I start that I don't want to use too many medical terms for the fact that people should not think that when they listen to this program, they can avoid seeing a doctor. The person who will diagnose malaria for you and treat you, and you are sure, is a clinical practitioner. Don't think that you can take some of these things we say, not because we're not saying them correct or not because they are not correct, but because they are not adequate for diagnosis and treatment. I must caution that before I continue. That said, with malaria, what happens is that when the mosquito bites, it injects malaria into the bloodstream, and then the parasite goes, the organism goes to the liver, develops further in the liver, and then comes back to the bloodstream. At the point where it's coming to the bloodstream, there's a rise in temperature. You know, at the time when the mosquito is biting, you may not notice anything, but 2 weeks down the road, when it has circulated in the body and gone through the liver and then come out of the liver again into the bloodstream, then you start having fever. Some people have headaches. Some people even have what we call rigor, shivering. People shiver. You know, the temperature is so high, they shiver. And then there is, because it is, when it comes out of the liver, it's going to be sitting in red blood cells and killing the red blood cells. Some people present with anemia. Because it's developing in the liver, there's a very important stage of development in the liver. It may compromise, some things may happen in the liver that will make it, and then added to the number of red blood cells that may be killed, people may present with yellow eyes. So malaria has a very diverse presentation, but the commonest presentation is fever. Sometimes they may even present with pain. You know, the liver pains, the liver becomes painful. And someone is thinking that he has abdominal pain. There's pain in my stomach. The doctor checks the person and discovers that the pain is from the liver. And that could even be because of malaria, because of the process of the development of the parasite inside the liver. It could produce liver pain. So that by the time it is getting into the bloodstream, the liver is painful. So there's a very diverse way that malaria presents. But it's important to know that once you see a clinician, the good thing about being a clinician in sub-Saharan Africa is that we have what is called, we are guided by what is called a high index of suspicion. Because in practice, if you don't suspect it, you will not look for it. But with malaria, in fact, everybody who walks into the consultation room, the doctor suspects malaria until proven otherwise. No matter what your complaint is, you know, and it is important for us because when that is done, then it is possible to handle it. Because if you don't handle it, well, as we are saying, it is killing the red blood cells, the person will die not even of anything but lack of blood. The blood anemia will kill that patient, you know, because the cycle will continue. Malaria will keep killing the red blood cells. But once you're able to put your hand on it and treat it, it is very important. Through the questioning of the patient and then a possible lab test or two, the doctor is able to say, okay, we have found malaria. There may be other things, but we have found malaria. Then it is treated. I wouldn't want to start naming molecules for treatment because I live in an environment where I know how people behave. They want to go into the shop and buy and avoid the consultation. They want to go into the medicine shop or into the pharmacy. It's not a good practice. The best way to handle any disease is to get clinical help. It is properly diagnosed and treated. Malaria can be treated. That's the good news. That's what matters. Through the years, we have had problems with the treatment. You know, at some point there is resistance to this and resistance to that molecule. More molecules are developed, but there is good treatment of malaria on the market. And in sub-Saharan Africa, where it is endemic, we have a lot of subsidized treatment. You know, WHO has worked with governments in sub-Saharan Africa, and there's a lot of subsidized treatment for malaria, which brings down the cost for the general population, and which is good news for the population. So people should not shy away from the hospital for fear of costs, for instance. People should go to the hospital. And that said, the other thing I want to say about malaria is that there's one presentation that is very important. If malaria gets into the central nervous system, that what do I mean? The brain, especially the brain and the spinal cord. It has a presentation that is a bit bizarre. The person's behavior. Somebody may behave a bit abnormal. You know, they may go into coma. They may be a bit delirious. So somebody may have delirium. Somebody may talk unusually. You know, talking irrationally and things like that. It will be malaria because malaria has gone into the brain. So that confirms that malaria has very diverse presentation. And when it's in that case, the doctor suspects it, and like I said, still checks it, and there are ways to treat it. Malaria that presents as malaria in the brain or cerebral malaria, malaria that presents with anemia, already clearly clinical anemia, malaria that presents with clear clinical jaundice, yellowness of the eyes, those ones are sometimes classified under complicated malaria or severe malaria. There's a treatment for it. So people should not shy away from the hospital. The good news is that malaria has treatment. That is a heavy disease, but it can be treated. That's what matters. And its complications too can be treated, all in the context of a clinical setting. Because people have the inclination to, oh, I feel as if I have malaria, run into the shop and buy 1, 2, 3 tablets and drink. That is a dangerous practice because it is the reason for much of what has been a clinical challenge to the treatment of malaria, resistance. Because if, like I described a while ago, malaria has about a 2-week stay in the blood before it produces symptoms of fever and whatever it's producing. So if in that 2 weeks it's developing the way it's developing, it tells us one thing we should know is that it develops in stages. So it goes from, just like any developing organism, it grows from one stage to another. I don't want to be using terms that sound confusing, but it goes from one stage to another. And those stages are handled by treatment. Now, if you go taking your 1 tablet or your 2 tablets and think that because the symptoms have reduced, you have treated malaria, you have given a chance for the different stages that are still in the blood to incubate and resurface. And now, because you have put in the medication, but you didn't put in adequate, and the particular parasite was not killed, it is sensitized, and it can now protect itself against the treatment. And so the resistance can develop. Then you realize that somebody will come and say, I'm always having malaria, because the standard treatment is no longer working for the person, you know, because there's now resistance. And the mosquito will bite this person, take this resistance strain from him, from point A to another person in point B. Then we start having a challenge clinically. Oh, people are not responding to malaria treatment. It has happened. That's what happened with a drug like chloroquine that many people knew about. That's one of the reasons why chloroquine is no longer on the market, because that resistance developed. And chloroquine was a magic drug for malaria, but it developed, people develop resistance. Resistance strains develop. Chloroquine could no longer kill the parasite, but the parasite, because of misuse of the drug, mainly, the parasite was able to develop resistance. Now it becomes a problem. So other molecules have been developed, and there has been a lot of evolution to the treatment.
Yes, but, that said, yeah, go ahead, yes. Go ahead.
Yes, so it is essential that when we are talking about these clinical and medical things, people should learn to just depend on their healthcare provider.
That said, let us just say this is Africa Online Media Corporation. We are broadcasting today. The topic is malaria. We are having Dr. Khumbah from Dakar, Senegal. But if you come on, please indicate so that we can call on you to participate. That said, is there anybody else who wants to give us their own point of view on malaria? Anybody on the line, please? Well, Dr. Khumbah, apparently there's nobody, so let us continue. I hope I did not disrupt your train of thought. So go ahead, please. I know that there is resistance, there's been resistance, but then what can we do to, first of all, preventing malaria is starting with killing the mosquitoes. How do we get rid of the mosquitoes? I know you are not an environmentalist.
Yes, no, I mean, there is preventive medicine is part of my clinical business, so it doesn't really need to be an environmentalist per se, but prevention, like I said earlier, is better than cure. It's what we grew up hearing, which is a very true statement. And one way to prevent, there are many ways to prevent malaria. The first way to prevent malaria is to control the mosquito. So how does the mosquito develop? How is the mosquito lifestyle? Mosquito grows, this mosquito survives in stagnant water, in
dirty environments generally.
Excuse me, yes, in bushy environments. See, not just dirty, but grass, you know, when there is wet grass, pools of water, there is, you know, when there's grass, there's always dew on the grass in the mornings. It nourishes the growth of that the Anopheles gambiae, especially Anopheles gambiae, female Anopheles gambiae. So we worry about the environment. Pools of water in cans, you know, we are now all into canned food. Eat this and throw cans around. Then water collects in them. Mosquitoes breed in those cans. You know, so if we keep the environment clean, it's the starting point. If we keep the environment clean, we reduce the chance of the mosquito developing, and therefore the chance of the disease being transmitted from one place to another, and so they will reduce malaria. It is very important. That is a key thing the key thing in the prevention of malaria is the control of the mosquito. You know, we're talking, I mean, the key is the environment. And in the environment, the emphasis I am making is on stagnant water. Because when you have water, no matter the quantity, that is hanging around and does not drain away, mosquitoes will breed. That's important. That's why cans are important, blocked drainages are important, pools of water in the middle of even farm fields are important because they breed mosquitoes. Now, the next step to the prevention is how to kill which mosquito has survived our clean environment. So there's insecticide. It's possible even that same environment can be sprayed. People spray their environment to protect from mosquito. So we can do a direct killing of the mosquito that has survived efforts to not let it breed. It is still breeding. Okay, we kill it with insecticide. Going a step further, we say, okay, some have still survived. People are still getting bitten by these mosquitoes and they are getting the parasite in their system. What can we do? We can prepare people's immunity by tablets. You know, there's possibility to take preventive treatment for malaria, and this is particularly of particular importance in children and pregnant women. Very, very important, because even a woman who comes to the hospital and is malaria negative, who is pregnant, we still want to make sure that the unborn baby does not get malaria before they come out, knowing that malaria is a big burden in children below 2. We don't want them born with malaria. So it's very important that malaria is prevented through tablets. There is intermittent. Let me not start calling treatment regimens, because as I say, I don't want people to take this for a prescription and start thinking that. But in that program, they said this, that if you go to the antenatal care clinic, or you call it the US prenatal, we call it the antenatal care, ANC. ANC has a lot of things that they do for the women. One of the key things is malaria prevention. So every woman who is pregnant must register in the antenatal clinic within the first 2 months. That's a malaria preventive measure you're taking. by registering yourself in the antenatal clinic, because part of what they will give you in the clinic will be malaria prevention. It's very important. And then there is therapy. Okay, now all this has been done. Everything has been tried. Malaria is still showing up. They have come with a fever and the whatever symptom they have, and then the test is showing that, oh, malaria parasite is present in the blood. Okay, there is malaria treatment available. Treatment in different classes. Is it a mild disease? Is it a severe disease? Is it a complicated situation? The different classes can be treated accordingly. That's why it's important to treat in the clinical setting. That's my emphasis, because you are able to identify, is this one simple malaria, complicated malaria, severe malaria? It's possible to identify that clinically, and the treatment is appropriate to the classification in that sense, because that classification mainly helps the treatment. And results are good when treatment is compliant. If the doctor tells you, take a tablet, for example, every 8 hours, and take for 5 days, and you do that, you clear that episode of malaria very conveniently. And many of the molecules on the market do not only clear the episode of malaria, they also confer immunity, which means people can treat an episode of malaria and stay for 6 months without malaria because they treated it properly. But it is unfortunate that people don't treat it properly. There are two problems with that. The first is that the patients are not very compliant. You know, since they had a severe headache, fever was very severe, the first 24 hours, symptoms have subsided. Oh, I feel better. You know, so I start getting careless with my tablet. I don't take the tablet I'm supposed to take and things like that. So I didn't take proper treatment. So in 2 weeks, as I was saying about the circle, that's why I was trying to get that background picture, because it's important as we go ahead. The malaria, the same episode resurfaces. So you have a patient who wants to the consultation and tells you, doctor, every month I have malaria. I ask you a simple question. Well, if you have malaria every month, then there's a problem. Because most of the medicines on the market confer some immunity. So why should you have malaria every month? Yes, mosquito is biting you again, but if you treated the lab episode properly, then you would have had some immunity. Everybody cannot have malaria every month. I mean, it increases the burden of disease unnecessarily. And this is patient behavior we're talking about. And then the other problem is that we have to deal with fake medications. I want to repeat the word fake medications. There is a molecule we know will work, but the one we bought from the market, was it the right type? Was it the right formulation? Reverend Pam should be in on this talking to her, but she's the pharmacist here. Was it the right composition? You know, because if something is supposed to have, let me say 10% of it is supposed to be the medication. You go and buy what has 1% of the medication, you are drinking, you're wasting your time. You will not treat, for example. So that's why controlled medications are available. Government policies in sub-Saharan Africa, part of what they do is to control these things. There are departments that control and import medications, in such a way that we assure that quality control is helping us not to put available to the people fake and poorly composed medications. The third thing that creates the problem is lack of access to healthcare. Some of the people in real rural areas I have seen, I say this with a very heavy heart, cannot even as much as find a clinic to attend. You know, so malaria becomes a problem for them. And even when they go to a clinic, who is in that clinic? It is poorly staffed, it's poorly equipped, it's poorly, there are no medications available, nothing. So you have people who cannot even have access to this, even the basic things we are talking about. But what happens is that in the typical African way, people have been able to understand from their environment what they can boil as herbs and drink, and they are using them. You know, it's helping people. People take herbal treatment for malaria, and it works. I don't want to start naming some things I have learned through the years that people use for treating malaria, but it works for them. You know, and it is helpful. So it's also important that even in settings where people do not have much access to healthcare, because access to healthcare is really an issue. We cannot deny it. It doesn't affect only malaria, it affects the round, the complete healthcare package of the population. Well, if you have that problem, then you must, in your environment, talk to be able to get advice from experienced people in the environment. You know, Africans have always had a way of making their things work. You know, not to say that civilization has not helped us, but to say that Africans can survive still. Even without civilization, they were surviving and they have been surviving. So in those places where they don't have access to regular hospitals or regular clinics or proper, well-equipped places, herbs are still very helpful. There are a lot of herbs that can treat malaria. That said, I want to say that malaria treatment is important, but does not end with treating the symptoms for malaria. I'm saying this because we have mentioned symptoms like pains in some parts of the body, headache, fever. What happens is that some of the medications that we give in the hospital are symptomatic treatment. So if somebody has an episode of malaria, the chances are that we'll give the person something for malaria as a molecule against malaria, but we will also give the person a painkiller for the pain or an antipyretic to reduce the temperature, you know. So it means that the person will end up with about 2 or 3 medications on the prescription. There's a risk that the person may not buy all the 3 medications for financial reasons. So it's important for the practitioner to tell the patient which one of those medications is the most important. Even if you cannot buy all the 3, I have written for you 3 medications. This one you must start because this is one that kills the parasite. But that too is an important part of the whole process, because when patients don't have money and then they go and buy paracetamol, for instance, that can reduce the fever and reduce their pain, they think they have bought medicine. They have not bought medicine, because the paracetamol will not treat the malaria. The real malaria molecule is still sitting on the prescription paper. It has not been bought. That's an essential issue, and it falls back on the clinician, the medical personnel, to explain to the patient. And that's why in practice, when people come to the hospital, you see that in the hospital most of the time there is a socioeconomic data. There is some data taking. What job do you do? What is it, so that we can be able to, at the time we are prescribing, know whether you can buy it or not. Those things we write on the paper are not for nothing. They have their value. So by the time I'm writing a prescription, I'm looking at somebody, they have written their farmer or housewife, or even if it's even a child and the mother is sitting there. The question now is, will you be able to buy these medications? If I'm sitting in a clinic, in a hospital, I call the pharmacy department and I say, I'm prescribing so and so medication. How much is it? I tell the patient, your bill is so much money. Will you be able to pay? If you can't pay, make sure you buy this one. It's very essential for the patient, because people end up seeing symptomatic treatment is a little cheaper than the real treatment. They end up buying symptomatic treatment. It's very important for the patient. Very, very important. Because if not, the patient goes home treating symptoms and comes back worse, because by the time they have treated the symptom, and then malaria is still recirculating itself, and the parasite load, the amount of parasites in the blood is increasing, then the patient will come back with more complications. They may even die. And then they'll be thinking, I was taking treatment for malaria, but they were taking treatment for pain or for fever, not malaria. You know, so those are important elements in practice that physicians need to pay attention to, and everybody involved in the chain of seeing the patient and getting the patient through, even the pharmacist. Because by the time the patient gets to the pharmacist, if he doesn't have enough money, the pharmacist should be able to educate them and tell them that, look, even if you don't have enough money, if I were you, I would be advising you to buy this one first, because this is what that will really handle the illness. Once the illness starts getting handled, the symptoms will clear. And that's why in practice, in some settings, especially where I studied and worked for the first 2 years of my career, for children below 5, it was not practice to prescribe symptomatic treatment. So if I see a child below 5, I will not give that child paracetamol when the child has malaria. I go straight to malaria treatment, because there's a high risk that they will go and take symptomatic treatment and that child will die of that disease. You know, so it's very, very, for me in clinical practice, these are very salient issues. No matter how much is available as medication in the hospital, the staff, the infrastructure, the whatever, the basic knowledge for the patient to know what to do best is a key thing. And that patient deserves to be told by the person in practice, by the health personnel they are meeting. That's why patient contact is, there are things the patient must know by the time they finish, but by the time they finish talking to a health personnel. If they don't know, then that health personnel has not done what they were supposed to do. And last time when we talked, we were talking about patient load. Sometimes patient load is a problem. So at every step, at the point of the reception, at the point when they are consulting with a prescriber, at the point when they are going to go and buy the prescription, somebody should talk to the person. Somebody should talk to the person, especially between the prescriber and the dispenser, the pharmacist. They should be able to educate the patient on their condition as best possible. Because what you know, you can handle better than what you don't know. I mean, ignorance, they say, we know what ignorance means. Ignorance is detrimental. Yes, so educating the people too is an important matter. Now, when we talk about prevention, we did say the actions that can be important. But those actions cannot be carried out by people if they are not educated. So it goes back to health education again. We have to carry out sensitization programs. When we talk about prevention, I deliberately did not mention mosquito nets because it has become like a drama in Africa, mosquito nets. But I'll come back to it. Because mosquito nets are now being impregnated with insecticides and distributed to families. They are not useless. They are a helpful thing. But for policy reasons and the way it's being handled, one may hope that, okay, how effective is it? It's effective in its own way. Research has shown that. But because of people have to get these mosquito nets, some of them are free, some are not free. There's a lot that goes on with acquiring mosquito nets and using them. They are preventive measures. That said, I mean, let me just leave it at that and say they are preventive measures. So mosquito nets are a preventive measure, even if they are not impregnated with any insecticide. Having mosquito nets in the home, especially for the beds that are used by children, is a very serious preventive measure.
Yes, Dr. Khumbah, just to let you have a sip of water while I ask this question. When we were growing up, there was something called moon tiger, something that people burnt around in their bedrooms at night. And some people said, no, it was not healthy because of the smoke, because of the incense or whatever that was in this, whatever they were burning. Some of these things are preventive, yes, but how long do you think one should continue to go that short route to be able to keep the mosquitoes away? We know that along the way also, the mosquitoes adapt to the environment and then they become even deadlier than before. Whatever they put in us becomes even deadlier than what they brought to us before. So what should the human being do? What should we, especially those of us struggling against malaria, what should we really do?
You see, moon tiger is still around. Moon tiger is still very much around.
Oh.
And you have rightly said so. You see, I want to say that even medication that we drink, every chemical that the human person uses is a potential poison. The only thing that helps is the amount that is safely used. So there's a safe range, but it's a potential poison. Moon tiger will kill the mosquitoes in the room, but it's a potential poison when inhaled continuously in good quantity. So usually, with the people who must use things like moon tiger, what they do is that they can burn the moon tiger while they're not in the room, keep windows and doors shut, burn it, and give time before they come back to the room so that the concentration has reduced. You don't have to inhale it. You don't have to be inhaling the smoke as it comes out from the whatever you are burning. The same with all the other sprays. You know, we mentioned the killing of mosquitoes. That's one of the ways that mosquitoes are killed. You know, insecticide, moon tiger is one form of insecticide. There are safer forms of insecticides. But in a general way, it is good to use insecticides when you are not in the environment. Even when you put them in your room, it's good to put in the room and be away from the room for a while so you don't inhale the chemicals because the air is laden with them. Once at the point where you are spraying or you are burning, the air is very laden. If you smooth that, if you inhale that amount of chemical, it's potentially dangerous for the lungs, obviously. So the practice would be, it would be good to For example, in a family home, before time to go to bed, at sundown, windows are closed and the rooms are sprayed, for instance. And then by the time it's about 2, 3, 4 hours after when people are going to bed, the room is mosquito free. And of course, it's also free of whatever was sprayed, because these things, they diffuse away, you know. But it is not a safe practice to burn moon tiger while you are sleeping, or to spray the room as you go to bed. You know, spray your room and close the door and lie down. Those are not good practices.
Now there is the mutation of the mosquito. I mean, it changes in shape and size, and the poisonous things that it carries around, or the viruses it carries around. Those two seem to mutate from time to time. Is that one of the reasons why medications sometimes are not really effective?
Yes, that contributes. That contributes to resistance, to resistance strains, because as they are mutating, they are producing, they are getting, and that's why I mentioned the what provokes that mutation. You know, if for example mosquitoes are sprayed and they are able to realize that, hey, my environment is at risk, they mutate. If malaria medicine is taken and it's not properly taken, the malaria parasite mutates, and then it produces a resistant form. It's mutation that produces resistance. But what is provoking the mutation is for the most part, chemical provocation by poor use, especially of medication. And it's very important, because if resistance continues to be a problem, then we need to continuously keep looking for new molecules. It's not easy. It makes the problem. It complicates the problem further, in short. And talking about prevention, we already mentioned that a vaccine was launched. It would be a very good thing for Sub-Saharan Africa if that vaccine can take roots. Because if there can be a vaccine for malaria, I don't know, after the health problems of Sub-Saharan Africa will be 90% solved.
But the African is already very skeptical about vaccines. I remember back in Cameroon in those days, there was this scare about vaccines causing sterility in girls and so on, and families were very reluctant to go for vaccines. Even in East Africa now, where they are trying that new drug, some families are still very skeptical about the truth about it, that it is actually anti-malaria.
Well, that is a very delicate area of discussion, because that is politics laden. That's a political area you're getting into. And the politics of these things, as we know, I mean, I don't do politics per se, even as partisan politics, because politics is, for me, capital D, dirty. So everything that humans do, the human being is a political being. They get political about what they are doing. They do political things. And what's the politics of bringing vaccines to Africa? That's what you are delving into. I don't want to delve into bringing vaccines into Africa.
Yeah, that's right. You're right. Yes. And Reverend Pam is on the line. Reverend Pam is on the line. Maybe she has a follow-up question to you, or a brand new question on malaria and its treatment and the complications around it. Reverend Pam. Oh, she may be muted. All the same, continue, Dr. Khumbah from Dakar, Senegal. Another aspect.
I am here.
Oh, okay, Dr. Goji, you're welcome to the program. Yeah, we're talking malaria. I know you grew up in tropical Africa. What was your experience, and what would you recommend for the man on the street right now about malaria?
Well, malaria is a very, very common African disease. Before I continue, as Dr. Khumbah have said before, there's a lot of resistance against medication for malaria or anti-malaria. I'm not very current with the current treatment for malaria because I've not treated malaria for years. But based on my general knowledge of malaria, it's a disease that kills a lot of people, especially children under the age of 5, and adults if they have not been exposed to malaria in the past. Just like if some of us have been here for 10, 15 years, we travel to Africa, we are like a 5-year-old in Africa with no immunity. Malaria is very deadly. Of course, to treatment of malaria, is very complicated. However, there was a question about taking medication over the counter for treatment of malaria, if it is right or wrong. My take on this is this: malaria is very, very common. If somebody in Africa has a fever, it's most likely malaria or to prove it otherwise. Therefore, it's safe to treat with anti-malaria before you start looking for other possible causes of fever. Only if the patient does not respond to the anti-malaria given, then we start looking for other causes of the fever. It's a safe practice and it's a very reasonable practice. So anybody in Africa with fever or fever illness is malaria to prove otherwise. We treat empirically. If it doesn't respond, then we say time to go see a doctor to find out what's going on and find out more and more about different causes of fever, and then do a test of malaria parasite. We take it from there. Of course, malaria is a very, very preventive disease, as I know. The first thing to prevent malaria is to do away with mosquitoes. No mosquitoes, no malaria. And to do away with mosquitoes, you have to do away with poor sanitation, especially those with open gutters, stagnant waters. Those things will cause malaria. Pit latrines. Anything that causes stagnant water will deal with malaria. In fact, I was in a meeting recently. One guy somebody was looking for a grant to do away with used tires in Africa. He's going to get he actually got a grant for that project because he used malaria as the reason for that. So there are a lot of empty tires, which kids are playing with tires all over the place. Tires lying down. All those tires have stagnant water that stays there for months to months, and that's a breeding ground for malaria. So that's the first thing. Then, of course, second thing is insecticide and pesticides. From insecticides impregnated mosquito nets to even spray. The body spray you can spray on your body late in the evening to prevent malaria, and to even barrier protection, like wearing long clothing with long sleeve and socks when it's evening time. These are things you can do to prevent malaria. Of course, for pregnant women, people at greatest risk of malaria in Africa are pregnant women and children under the age of 5. That's why every pregnant woman in Africa, when I was practicing there, will prescribe malaria prophylaxis for them. I'm sure it's still the standard practice. You are pregnant, they place on anti-malaria prophylaxis or intermittent treatment for malaria, so you don't develop malaria. That's a long-term consequences on your pregnancy, your unborn child, and even your health.
Now, doctors, Dr. Ogoji and Dr. Khumbah, are there any particular ways of testing malaria in somebody when somebody presents in the hospital? Is there something to do as a test? I know there is one of us who contributed on the forum during the week. He said of having developed a urine test or something. So are there other methods of testing patients or potential patients for malaria?
Well, I think let me just make one comment on this and let you talk, okay? So I was in Kenya last year, and there's a point of care testing for malaria. I'm not sure if it's available all over Africa. Just like blood sugar testing, patients, I went to Kenya for a medical mission. In that clinic, they don't give anti-malaria without testing because they have the point of care testing. You come in there, they prick your finger, get a drop of blood, put it there, positive, negative for the treat you. If that test is affordable as in Kenya, it's also supplied by the government of Kenya for free to rural Kenyan population. If it's not affordable, then that should be the standard point of care testing for treatment. That's my take on that.
Dr. Khumbah, before Reverend Pam.
Yes, there are ways of testing for malaria, and Dr. Ogoji has just described one of them. The standard remains the drop of blood under the microscope. That remains the standard test for malaria, because in that way parasites can be seen and even counted. But like he has described, there are other tests that have developed, especially those tests that are rapid tests, because the one with the drop of blood takes a couple of minutes and may take an hour, and you may not have that time, especially with patient load and if the patient is very toxic. So the malaria is diagnosed by lab tests. Yes, there are tests for that. It's a standard practice. And just as Dr. Ogochi was saying, it is really, really getting more grounded that it is not a good idea to give treatment without testing for malaria, even though there are negative, there's what they call smell negative malaria, which means the patient has malaria, but you don't even see malaria in their blood. Because the amount of malaria in the blood is important. The quantity of the parasite is important. And we are pricking the tip of the finger to put under the microscope. So to some extent, the drop of blood which is used in just like he was describing, the test is similar to the test of blood sugar. You just drop a drop a drop of blood at the tip of some strip and see the results, whether they are positive or negative. That is a very good test. And it is helping. It is all over the place. It's not only in Kenya. He said it's only in Kenya. It's all over the place. It's being used everywhere in Sub-Saharan Africa. It's being used in many places. The only difference may be that some governments might have subsidized, some governments have not subsidized, but it's available. It's available.
Okay, Dr. Khumbah, take a breather. Take a breather. Reverend Pam, it's the top of the hour. She usually makes announcements at the top of the hour. I believe she's on now, Reverend Pam. Muted again, still muted. All the same, let us say this is Africa Online Media Corporation. We're discussing malaria and its consequences. Is it a scourge? Is it something to celebrate? No, that person I would say no. So what do we do with malaria? Now, Dr. Khumbah, we're talking about prevention. We're talking about taking medications and so on. So where do we go from here with malaria? It is still that elephant in the room. Oh, Reverend Pam, yeah, we can hear you faintly, but try again. Adjust. Yes. Do you hear us?
Oh, can you hear me? I'm having technical difficulties, but anyway, can you hear me now?
Yeah, go ahead.
Okay, I'm going to make the announcement very quick, and then, I'll hand back over to you. Well, Dr. Khumbah and Dr. Ogochi, thank you so much for your faithfulness. Starting tomorrow, we're going to be revisiting a topic that we have treated for 3 years in a row. It's the marriage series that we do. Actually, earlier this year in February, during Valentine's Day, we had this topic, but we are going to do a series because last month we announced that we're going to do it in the heated debate of domestic violence.
We lost you. Hello, Reverend Pam. We lost her, but what she was saying is that for the month of, for the weeks following, I think the next 3 weeks or so, we'll be discussing marriage. Before you say, yes, I do, what should be topmost in your mind before you say, I do? And after you say, I do, what next? So we'll be having a series on marriage before you get married. What do you do before you say yes? How do you say yes? When you say yes, what next? So I believe that will be the topic. We'll be framing an introduction and posting it on our chat room. So let's go back to Dakar, Senegal. Dr. Khumbah. Yes, malaria, the elephant in the room.
Yes, malaria. Malaria, we have painted a good picture of the weight of the problem. So what we need to do, if we're talking about what to do next, is to educate ourselves about it. Because there's nothing as bad as ignorance. You'll be surprised that despite the weight of that problem, many people living in Sub-Saharan Africa are still ignorant of the problem. So educating the people and getting them to understand better how we have described prevention, better how to do prevention and what to do with themselves when they get sick is very, very important. Because if many people knew what to do and did it right, we will be winning the game against malaria. But many people don't. Like I said earlier, that's one of the reasons why even we use medications wrongly, inappropriately, and end up with resistances, and pharmaceutical people have to start going back to the lab to look for another molecule that can kill malaria. Right now, we are on what we call ACT, artemisinin-based combination therapy. A single molecule can no longer kill malaria. So now we have combination therapy. So if we have 2 or 3 molecules already that we must use to kill malaria, if we are not careful and when we end up with 4, we know that each molecule we take is a potential poison. So it is a problem. It is a problem. People need to know and know and know, because the more they know, the better they can behave. Because this thing, every disease has a behavioral pattern that affects it. In the case of malaria, because it is so endemic, the behavioral pattern is that of poor treatment. It's classically poorly treated, very poorly treated. And because of access, financial access is difficult. Somebody needs treatment for 5 days, he ends up buying treatment for 2 days because he cannot afford the 5 days. These are all problems that people need to be educated to understand. Even if it means you will borrow money if you can and take your treatment, because in the end, it is good for the people. You see, you live in a part of the world where there is a lot of healthcare or Medicare, whatever you call it, there's a lot of insurance. Back here, it's very difficult to get insurance covers. It is very difficult to get insurance covers. So access is still very difficult. But in communities where there is some insurance cover, it is okay. When I talk about insurance cover, we have both commercial insurance, the typical insurance situation, but there's also what is called community-based health insurance. And if that were to take roots, it would be so good for the people, because it will be possible that some people can spend minimally annually and at least have access to malaria treatment. It is very, very important. Back in Cameroon, this community-based health insurance thing I'm talking about was put in place by the church in the Bamenda Church province, which is in northwest and southwest, which we know how it is there now. And they used to call it BEFA. That thing was helping people. You know, it's helping people. If people can just know what to do to have access to healthcare, what to do with what they receive from the healthcare provider, what to do before they get to the healthcare provider, and what to do after they have finished their treatment, I think it will be health education of the community is a key issue. Because way back in 1978, when Ama-Ata was held, when the WHO held their famous Ama-Ata conference in 1978, the idea was prevention is better than cure. How do you prevent without educating the people? That's when health education took roots. That's when public health took roots. But we are not educating the populations. We are not. That's a big, even though this, for example, that's why I like what you are doing on this program. Because anybody who is listening to what we are doing here should at least learn one thing, and that thing should help the person. Because there is nothing better in disease prevention than education about the disease. Once you have the education about the disease, you know where you're going, and it's a better thing. You know, so I would say that, where do we go from here? Insist and increase and expand the education of people.
Yes, so at whose doorstep do we lay the blame? Is it the government? Of course, I know there are always the people to whom fingers are pointed. Is it you and I? Is it the community? Who is to blame?
I don't want to call it blame. I want to say that it's a challenge. It's a challenge because I give you an example. One of the good portals for education on any disease at all, and especially malaria, is what I call the antenatal care, the ANC clinic. The ANC clinic is the place where a lot is taught to the woman, including some of these problems that are endemic, like malaria in her and her unborn child, and her child until the child is 5 years old, nutrition and all those other things that will be involved in the child's life. But the question is, how many centers deliver that package properly, number one? Number two, how many of the women are listening as they should listen? Number three, those who even listen, how many implement what they hear? So there's no finger pointing to anybody. I think it's a community issue, and the community should handle it as a community issue. We should not worry about whether it's the government or we should just say that at our own level, as members of the community, what we can do, we should not relent our effort in doing it, because finger pointing will not change the situation, number one. Finger pointing, I mean, I'm a doctor and I'm sitting in my consultation room and I didn't explain to the patient the prescription I just made. The government will not come and do that, you know, for instance. So for me, it's everybody in the picture who should sit up and do what they need to do.
Thank you. Let us see what Dr. Ogoji has to add. Dr. Ogoji.
Well, my take on this is simple. Health education is very, very important, as Dr. Khumbah just said. But going by experience, having practiced in Nigeria and now practicing here, and Dr. Khumbah may or may not have some experience. When we were growing up in Babida those days, you know, when my parents take me to the hospital, in general hospital for checkup, we used to get free anti-malaria treatment, free vaccines, and we took them then. As time goes by, there's nothing free again. Even those days in Nigeria too, from what I heard, you go to government hospital, you get a free treatment, you get free anti-malaria and free vaccine. Those things have changed. That's one. Number two, patients don't want to come see the doctors to get education. They rather go to see a chemist and say, I want mixed medication for 5 naira or 5 francs or 10 francs. They give the chemist 10 francs to give him medication for malaria. The chemist look at which is brain and say, okay, you give me 10 francs or 10 naira, I'm going to give you 2 naira worth of medication and put whatever he wants to give and give to you without saying, hey, for you to get a good anti-malaria, you need 50 francs or 50 naira to get a complete treatment. That's second thing. Number 3, we doctors there, why practice? I remember I was also Kyoto. When I prescribe medication for my patient, you know, I tell the patient the name of the medication and give him the patient full direction how to take it. The patient write down the medication, write down everything, and becomes the next doctor for his family. So when I went to the doctor with X1B with ABC complaint, the doctor gave me this medication to take it this way, this way, this way, this way. And now you have the same complaint, please take it this way, this way, this way, this way. So it's not uncommon for Nigerian doctors in Nigeria to dispense medication to their patients without telling the patients what exactly they are taking. I'm not saying it's right. I'm not saying it's morally right, but it may be financially okay to save their business. They'll just so they'll give them a mixture of medication, say you take 4 today, you take 4 tomorrow, you take 2 tomorrow, in doses of chloroquine. So they'll give you the correct dose, but they won't take this chloroquine. Say you take 4 of these today, you take 4 today, you take 2 tomorrow. They won't tell the patient the name, don't discuss the side effect. It's not right, don't get me wrong, but if you do that to a family, the next person sick is not coming to you to get treatment. So the whole thing boils down to economics, poverty, and governance. Economic, poverty, and governance. And of course, we the people also have blames, because we blame the government, we blame everything, we blame the people. Because you should know that if they give you medication, it's for you. You shouldn't go and start sharing with other people. Even the health insurance is talking about, there's a good health insurance scheme in Nigeria now that was formed about 5 years ago for families to pay in every month and then they get free care. Of course, they pay a little more, a little amount of money. But I've seen a family, one person who works for the government, he gets insurance for herself and her children, but if her mother is sick, the mother calls and claims that to be her daughter. Or the mother goes to the doctor and gets treatment. So the system will only collapse because I have insurance, all my family, maybe my grandpa, my grandpa will go to the doctor and claim my name to get treatment. The doctor knows that I'm not the one, but the one money. So if you have insurance, you'll be treated like 20 times for 20 conditions for the same insurance because they're trying to save money. So where do we go from here is education, but for education to make sense, we still have to point to the government. Let's solve the hunger problem. If we are not hungry, you start thinking of health care. If we are hungry, you don't want to spend 100 naira or 100 francs on medication. You want to go buy food until you're dying. That's my take on this.
Okay, Dr. Khumbah.
Yes, I mean, what Dr. Ogoji is saying is so pertinent. You see, he has confirmed that it is a complete circle. We are not pointing a finger at a particular person at this time. It's a complete circle. And what he is describing people becoming doctors in their families is, you know, even when you are, even if they don't, someone doesn't even have to be sick. If you have ever been in a situation where you yourself you are taking medication, and maybe you are attending an occasion, a family occasion, or you are in a family house and there are many people, and it's time to take your medication, then you take out your pack and say, please give me a glass of water. Somebody will say, please, what medication is that? Can you give my own? It's a difficult thing. That's why it is still education that will solve that problem. Because the question is, why do you want to take medication? Why do you need it? Which one do you need? And what did your doctor tell you? The doctor didn't tell you this, yes, but even if the doctor gave you medication and did not tell you, how are you supposed to use your medication? It boils down to education. And people are poor, yes. People are very basically poor, and they want to use their next dime to buy bread, not medication. Yes, that's why also he mentioned free treatment, even in Cameroon as we speak. I'm not sure about Dakar practice clearly, but the practice in Cameroon where I have really worked most of my life is clear. Malaria treatment, the full package of diagnosis and treatment in pregnant women and children below 5 is free in Cameroon.
So education, eradication, how do we go around getting the education to the people if the governments are not stepping up to the plate to make that education available or to make it possible for the medical people in the field to propagate the education? How do we eradicate malaria? Shall we one day smile and say, oh, gone is malaria?
You see, I really don't like, let me say, as a person, I take the challenge rather than put it on another person most of the time, because when we say government, you see, Dr. Ogochi described a certain setting, especially what he described with relation to the insurance system, where people fake who they are. When we're talking about government, we're talking about a complex system, which is very, very corrupt. It's laden with corruption. But if I, as a community member, can choose just my small community and work on educating people around me, I am getting somewhere. I have done that for 20 years in Cameroon. Personally, with my own resources. I make sure, I attend women's meetings, give them lectures on these things. It's knowledge, it's free knowledge. I have been mocked a few times by a couple of who have said, Dr. Khumbah, you give knowledge for free, that is not good for you. How will you make money? The question is, how do I make money on poor people?
That's it. Can I get water out of the stone?
It's as simple as that. Go to school, tell the children in school what they need to know, tell the teachers what they need to know. I've done it in Cameroon for 20 years as a person, you know? So it's not difficult. For me, it is just a matter of the goodwill and the community spirit. As a person with the knowledge, what are you doing with it? The challenge goes to those who have the knowledge. What are you doing with it? You're keeping it to yourself and looking for how you can make money for you. How much money can you have that will be enough as a person? There's a saying in my vernacular. I don't want to use vernacular here. Some will understand, but the others will not understand. But
I know.
Money is never too much and it's never enough. That's the reality. It's like that.
Yeah, that's right. Yeah.
It's never enough and it is never too much. So for me, it's a matter of look at your community. Do you love your people? Do you love your community? To be honest, it's one of the reasons why I personally have spent all my life in Africa. Because I ask myself, what will I do my knowledge out of Africa? It's better for me to use it in my community. I give lectures in schools, in meetings, in the church. Talk to people. Talk to people. They will listen. Even if you talk to 100 people and only one person ends up hearing you. And
you're getting lost. Oh, okay, there you come.
A commitment issue in individuals before we get to the state. Because the state, who is the state? This is a whole corrupt system we're talking about. We want to be getting into these things where, okay, they have said, I've just said that malaria treatment is free in Cameroon for women, pregnant women and children below 5. But sorry, many people are still paying for it, for instance. You know? So
that's right.
The policy is there. If you read policy and see what is on paper, it is very nice. It's very, very, it's good for the people.
But implementation. It's a problem.
Malaria medicine is available for
I can take a take on this
there
too.
are bottlenecks for delivery. into the system. It is not coming, it's scarce. You still go to the pharmacy and go and buy because it is not even available where it's supposed to be available. That non-availability is not because there is no policy, it's because there's corruption in implementing the policies.
Dr. Ogoji has a take too.
In the process, so the problem.
So
for me,
my
as
take here,
and as members of that community who have the knowledge, we should take individual responsibility first and make sure that we are doing what we are supposed to be doing. And then the rest can follow. Whatever government can achieve, the government is achieving because the government never stops working anyway. The state is always on. The state machinery is always functional. There are always policies on the paper. There are a number of them being implemented. But how much of it is it getting to where it should get is the question. But as a member of the community, by the time I attend a women's meeting and talk to 30 women, I have talked to 30 families in my rating. For me, that's more than what government can do. That's my honest take. Because no matter what you do, I mean, we had radio programs in the common Pidgin language. You know, we go to the FM radio and talk in Pidgin between very high, how do they call this? I've forgotten the language that journalists use, but you know, prime time. Okay, that's the word.
Prime time. During prime time broadcasts.
Particular program, you come in 5 minutes in advance and say something before the program starts. They have tuned in, they have heard you. For me, it is individuals should really, the more we take responsibility as individuals, the more our communities will get better. That's the reality in my own understanding. Because we pay taxes, these taxes are used by a system called government, but sorry, the system is corrupt. That's the reality.
Okay, Dr. Khumbah, be preparing.
I don't want to give percentages because there's no research in my. I'm not doing
be
research.
Preparing your last words, and we go to Dr. Ogoji. Dr. Khumbah. Yeah, we want you to prepare your wrapping up statement or your closing statement while Dr. Ogoji comes in to say his own take on this.
Where do we go from here? Let's take our lives into our hands and be responsible for ourselves and be our brother's keeper.
Indeed. Thank you, Dr. Ogoji.
Well, my take on this is I want to go to talk to other people in the community who are leaders who have greater influence than us doctors.
See his picture, but I don't hear him.
Doctor, he's talking. I can hear him.
Okay, can you hear me?
Dr. Ogoji, go ahead.
Yeah. I said our take here is that we in Africa, the religion has a very.
I don't know if you hear me.
Dr. Khumbah, we're hearing you.
I can hear you very well.
Yeah, we're hearing you very well. He's hearing you.
I can hear you very well. So my take here is we in Africa are very religious. Okay. So to educate the community, we have to go to the churches. Hopefully the churches would stop or combine, stop preaching, come to me and everything will be solved. They should preach. You come to me, I'll pray for you, and God will help you feel better.
I can't hear anything.
He's talking, Dr. Khumbah. Dr. Ogoji is talking. Yeah, Dr. Ogoji, go ahead.
Come to me, I'll pray for you, I will be fine.
Not coming through
but
well.
it's also
Both of you.
Oh, Reverend Palm, if you are available, try to see what is wrong, and maybe at your level. Since you're streaming the program, try to see maybe some button was not properly adjusted.
Can you hear me now?
Ogoji, go ahead.
Okay. So my take here is on the religious part of it, you know. I know in communities in Nigeria, the priests, the pastors have a lot of power. So they should be the one telling the community, if you have malaria and you're under 5 and you're pregnant, you should go to the government hospital, it's free care. When the government gives you that medication, please come here, I'll bless it for you to work better. So go to the hospital, get medication, then come see me, I'll bless it for you to work better. That's what they should say. Rather than say, come see me, I'll pray for you, and it's all gone. That's one. So we must involve the churches in education in Africa, as well as the traditional rulers, because there are two people in Africa who believe in religion, they believe in the pastors so much. Those who believe in the traditional ruler believe in the traditional rulers so much. Those people, we must combine them in healthcare and health education. And hopefully they will see us medical professionals as partners to get the community health rather than competitions, you know. So what am I trying to say? It is very common, I know that it's very common in Nigeria, I'm not sure about other African countries, where somebody will having seizure or convulsion from malaria. A 5-year-old having malaria and with convulsion, the mom rushes the child to a pastor to go and pray. Nothing wrong with that. Pastor pray, but please, after my prayer, please go straight to the doctor to get anti-malaria, bring down the fever, you come, we keep praying. That's where you should go, because that's so. So the way forward for the education must involve these two people in Africa, the traditional rulers and the church. And then they should look at the healthcare professionals as partners rather than competitors. That's one. Number two, when we also try to talk about healthcare and prevention, the little thing people can do to stay healthy, you know, I've been to a lot of home visits here in America, go to my patients' home to see what they are doing. It will surprise you. There's little things that they can do to make a difference. So there should be trained community health workers in Africa. We have them to go to houses and say, hey, this gutter needs to be closed. This window needs to be, I mean, there are things you can change in household. Fix your window net. Keep your door closed after 6 p.m. This bucket water should not stand here. This tank needs to be closed. There are simple little things that can be done that will go a long, long way to change health. You know, you need to go to the patient's community and find out what is going on in that community. If you don't find out, you can't fix it. That's number two. And number three is being honest to yourself. What do you really want? And people be honest with themselves, again, boil down to education. As you rightly said, we provide education for people to do, they take what they want to take from you. If you're honest to yourself, I say, hey, and I keep on telling my patient, I use myself as an example, I can be clear, I'm poor, I don't have money for medication. The moment I die, the poverty, I'll leave money. So be honest with yourself, one thing, people are poor for right. To be honest, they are poor, but all of them have money somewhere. They might have money, they might have things that will try to save that money for something more important, for burial, for clothing, for this. So be honest with yourself means that you should be able to tell yourself the truth so that you can actually prioritize your needs. Health number one, health number two, health number three. And then food comes with health. The another can follow.
Thank you so much, Dr. Ogoji. Dr. Khumbah, I know you're about to go to bed sooner rather than later. So your last take on malaria and the scourge to Africa that it poses.
Well, I lost you for a few minutes. I didn't hear what was going on anymore, but I'm glad to be back to give at least a summary statement and say that the education of the basic person is the basic thing we must do. And we wish that if we do the education, people should take what we say. And you see, the worry about education is people not taking what you say. It's a very genuine worry. But I have come to learn through the years that if you talk to 100 people as your statistics, and 2 or 3 benefit from what you have said, is a successful talk. You don't need to convince 100 people. Convince 1 or 2 or 3, and something would have started happening. That's my take on it. Just let's not relent our efforts in educating the people. Let's not worry about the low response to our education. Once there's a response, there's a response. And we really, really need to take responsibility and take action as much as possible. It's not really about malaria, it's about our health in general, you know, and malaria being a very peculiar problem. We are talking about it specifically, that it kills, it can be handled, it can be prevented. Let's work on it. It can be treated. There are other diseases that cannot be treated. It can be treated. So let's work on educating ourselves and teaching our people how to prevent it, how to take care of ourselves when we are sick, and avoid across-the-counter medications as much as possible, because they are inconsistent. They are more fakes than in more organized setups. So as much as possible, let's get the right information and use it so that we can be healthier people.
Thank you so much, Dr. Khumbah from Dakar, Senegal. Thank you, Dr. Ogoji from, I believe that is Seattle, or one of those north, Spokane, Washington State. Thank you very much. And Reverend Palm in somewhere in Houston, not actually in Houston today, but somewhere in Texas, that is. Thank you all so much. My name is Assangle Frank Kemleke. It's been a pleasure, and please prepare your minds. Marriage before you say yes. So please, before you say I do, what should be behind your mind? It should not be to come in today and go out tomorrow. So that is my take on that. And we will be talking tomorrow and next week. Please join us on the forum and share your views. But next Sunday, that will be the first Sunday in November. Thank you all so much, and bye for now.
Bye, bye, bye.
Bye, bye.
Bye.